The query that was asked regarding uh, high sensitivity cardiac troponin levels and how to check and what is the guideline regarding at what levels to check. So, rule in and rule out is what was the protocol which was given by the by the European Society of Cardiology. Okay, so initially, previously, the two what the 2015 guidelines had suggested was the 0 and 1 hour rule. Okay, and then an additional testing at 3 to 6 hours. So that was what was the class 1B recommendation in 2015. But nowadays that has changed a bit. Okay, sorry, I can't move my slides. Hello,
Uh,
hello. I'm not able.
2015 and 2020 slide is visible. If you
Uh,
can, yeah,
just
now
a sec.
I'm able to see the next slide.
Yeah,
Yeah.
yeah, yeah.
Cool.
I was not able to move my slides. Okay. All right. So here is the basically the guideline that is given. So we have chest pain. A patient has come with a chest pain. Okay. So whether there is a history of or the physical examination which is suggestive of ACS, the new ischemic signs are present on the ECG or not. Okay. And the troponin levels, the baseline troponin levels, whether it is less than 5 nanogram per liter or it is less than 12 nanogram per liter, and after 1 hour the increase is less than 3 nanogram per liter. Okay, so here is the 0 2 hour, the 0 1 hour rule. All right, please listen carefully. 0 1 hour rule: if it is less than 3 nanogram per liter, all right, yes, sample after 24 hours, see if the patient's symptom, whether the symptom onset, whether you have taken the troponin levels after 2 hours or not. So 0 hour, 1 hour. Okay, 1 hour increase less than 3 nanogram per liter. Then you see whether the sample has been taken after 2 hours or within 2 hours. Okay. If the symptoms does not exist, then it is a low risk ACS. That means no further testing is needed. But after 2 hours of symptom onset, if it still persists, then go for an additional 0 hour and 2 hour test. Okay. And here you check whether the troponin levels are less than 12 or the increase is less than 3 nanogram per liter. If it is less, then you have successfully ruled out ACS and it is a low risk ACS. All right. Remember, we are not just seeing the high sensitivity troponin, we are also seeing the clinical physical criteria as well. Okay, so this is low risk management of the ACS. However, if these are not ruled out and patient has the symptoms and the ECG signs as well as the troponin levels. Okay, when we have the troponin levels more than 52, okay, plus or there is a high risk history and physical examination with a high sensitive troponin level of more than 14. So it is either an individual level of more than 52 or a level more than 14 with the history of physical examination that we have, or the new onset angina, or the ischemic signs of ECG, then there is a high risk of ACS, which is the recommended management, and measure the additional high sensitivity troponin at 6 hours after 0 hours. Okay? So here is the 0 6 hour rule. When you have a high risk of ACS, you are suspecting. Okay? If this criteria is also not fulfilled and you know it is not a low risk, then we classify it as an intermediate criteria. And in the intermediate criteria, you consider the differential diagnosis, as we have seen that there are multiple differentials of high troponin levels. So consider those differentials. Additionally, test the troponin between 3 to 6 hours. Check the troponin levels after the 0 hour. That means you check at 0 hour and you check between 3 to 6 hours, unless there is no longer any suspicion of ACS, but it has to be further evaluated with other tests. Okay, I hope there is no confusion. So we have the 0 hour, 1 hour rule or the 0 hour, 2 hour rule if patient has come within 2 hours, okay, or after 2 hours. Then we have the 0 hour rule, which is followed by the 6 hour rule, and then we have the 0 hours and the 3 hour. Earlier it was only 0 hour and 3 hour rule. So as we see 2015 class 1B recommendation, rule in, rule out, 0 1 hour and then 3 6 hours. This was the only rule. But now we have divided it based on the risk factors, and the ESC 0 1 hour algorithm at 0 and 1 hour is considered. Okay, that is a class 1B recommendation. Additional testing after 3 hours is recommended if the first two cardiac troponin levels of the 0 1 hour algorithm are not conclusive and the clinical condition is still suggestive of ACS. Okay, that is the intermediate one where we said 0 1 or 0 2, and then you do it between 3 to 6 hours. As an alternative to the ESC01 algorithm, it is recommended to use ESC02 algorithm with blood sampling at 02 hours. This is mainly for patients who have come after 1 hour. Okay, so 0 hour and 2 hours. And then as an alternative to this algorithm, rapid rule out and rule in protocol with blood sampling at 03 hours should be considered if the troponin level with validated 03 hours algorithm is available. So basically, if you really want to simplify, just follow this protocol. Okay, so the 0 hour rule, 0 hour 1 hour, 0 hour 2 hour rule. If there is a high chances of an ACS, you can repeat after 6 hours, and if there is an intermediate charts, repeat after 3 hours, 3 to 6 hours. Okay, I hope I'm clear on this. We'll go with the next topic, which is the etiology and the management of right heart failure. This will be the flow of the discussion of right heart failure. Introduction. Right heart failure, it is a clinical syndrome which is caused by dysfunction of the right heart structure, right ventricle predominantly, or the tricuspid apparatus, which results in the impaired ability of the right heart to perfuse lungs at normal CVP. Acute right heart failure, it is a syndrome which is characterized by the inability of the right ventricle to generate enough stroke volume, thereby resulting in systemic venous congestion, underfilling of the left ventricle, and in most advanced cases, cardiogenic shock. And the estimated mortality in such cases is around 6 to 14%. Coming to the etiology, so the etiology can be divided based on the physiology of the patient. Okay, so physiology of the patient, we have the increased RV afterload, impaired RV contractility, increased RV preload, and decreased RV preload as well. So increased RV afterload, pulmonary artery hypertension, secondary causes of pulmonary hypertension, pulmonary venous hypertension, pulmonary embolism, HPV, mechanical ventilation, post-cardiothoracic surgery, acute chest syndrome as in sickle cell disease, they can also come with this, pulmonary stenosis and tumor emboli. Impaired right ventricle contractility when patient has come with a RV infarction, cardiomyopathy, sepsis, okay, arrhythmogenic RV dysplasia. Then increased RV preload, it can happen in TR, in PR, in post left ventricular assist device, and in septal defects. Decreased RV preload in superior vena cava syndrome, tricuspid stenosis, cardiac tamponade, hypovolemia, and even capillary leak. So why is the RV unique? Okay, what is it about RV that is different from the LV? So first of all, the morphology wise, it is a low pressure, low resistance, high capacitance system. That means much less power is needed for the RV, and it is much thinner, around 1/3 less the muscular capacity than that of the LV. There is a thin valve with 2 muscle layers, but in case of an LV, it is a thick valve with a 3 muscle layer. Okay. Then RV is more compliant. It can accumulate large variation of venous return as compared to that of the LV. Okay. Without altering the end diastolic pressure. Each systolic contraction for the RV is there is a longitudinal shortening, but in case of an LV, it is a circumferential shortening. Okay, 40% of the RV systolic function is dependent on the septal contraction. Then, because of its thinner wall and higher dependence on the coronary perfusion, as we said, mostly it depends on the septal contraction, the RV perfusion is more vulnerable to an increase in the RV size and the systemic hypertension. So, there is greater sensitivity to changes in the afterload. Okay, as stroke volume rises, the change in that of uh, the pressure in that of the right ventricle, okay, the change in the afterload of the right ventricle, that is it decreases immediately compared to that of the left ventricle. And there is also ventricular interdependence, where an excessive RV volume loading will constrain the pericardium, and it results in compression and the D-shaping of the LV volume. Overload in the RV, thereby indirectly, which leads to decrease in the LV stroke volume. Pathophysiology. So pathophysiology wise, whenever there is an right ventricular failure, okay, it can happen due to various causes, as we mentioned: excessive preload, right, reduced inotropy, reduced lucitropy. All right, it can happen because of various factors. All these factors can contribute to what? So there, because of the excessive preload, what can happen? There will be a leftward septal shift. Whenever there is a leftward septal shift, there is increase in ventricular interdependence. So this is one of the most important mechanism of heart-lung interaction, and this can result in decrease in the coronary perfusion pressure, worsening the myocardial ischemia. All right. So whenever there is initially, when the right ventricular failure is happening, it starts with a right ventricular dilation. All right. There is a right ventricular dilation which results in the leftward shift of the left ventricle. All right. So this is one of the mechanism. Right ventricular dilation also worsens the tricuspid regurgitation, resulting in the congestion of the right side, which is the hepatic venous congestion, renal venous congestion, which further worsens the fluid and sodium retention and worsens the pulmonary pressures, resulting in a lower pulmonary compliance. Okay, and this also worsens the ventricular interdependence. On the left side, what happens? So basically, on the left side, this all this can further be worsened by the ventricular remodeling, hypertrophy, and fibrosis. So these are all interdependent, and each of them can cause a vicious cycle to occur, resulting in ventricular remodeling, ventricular dilation, right ventricular dilation, worsening of tricuspid regurgitation, and finally hypertrophy and fibrosis. At the end of the day, all of these will result in a decreased right ventricular output, decrease in the LV preload, and decrease in the LV output, resulting in shock. Okay. Molecular mechanisms consist of hypertrophy, apoptosis, okay, ischemia, metabolic dysfunction, fibrosis with increase in the inflammatory cytokine and collagen synthesis, increase in the reactive oxygen species, reduced oxidants, neurohormonal activation, and reduced fatty acid oxidation with increased glycolysis. So how are we going to diagnose? It is diagnosed, first of all, initial evaluation, symptoms of the right heart failure. Patient will come with dyspnea, abdominal fullness, lower extremity edema, right upper quadrant tenderness, exercise intolerance, and fatigue. Associated disease need to be ruled out. There might be a social history as well. Okay, and family history of PH and left heart failure, sudden cardiac death, ARVC also need to be ruled out. Physical examination, raised JVP, with a right ventricular heave, loud P2, tricuspid regurgitation murmur, pulsatile liver, hepatojugular reflex, ascites, and pedal edema might be present. Laboratory findings: patient can come with increased BNP levels, ABG, blood lactate levels which might be high, chest X-ray suggestive of maybe an edema, and a D-dimer level. Right axis deviation on the ECG is common, and patient might come with a P pulmonale with atrial flutter or atrial fibrillation. Cardiac catheterization is indicated when non-invasive testing is inconclusive. It helps to directly quantify the right and the left heart failure. PA pressures and cardiac output can also be measured. So echocardiography findings, there might be pericardial fluid more than 5 mm during diastole. RV valve thickness is increased more than 5 mm. There is dilation of the IVC. Okay. Tricuspid regurgitation, peak systolic velocity more than 2.8 meter second, uh, per second. TAPC less than 17. RV dilation. So RV is to LV ratio more than 1. So the size ratio, RA-RV dilation is seen. RV fractional area change of less than 35%. Okay. Then ventricular interdependence with shifting of the ventricle towards the left, causing a D-shaped ventricle. And then we have the systolic velocity of the tricuspid annular less than 9.5 centimeter per second, which is uh, uh, and then we have the longitudinal strain of the RV free valve less than 20%. So on and so forth. So majority you have to, the things that you shouldn't forget are the RV valve thickness, the tricuspid regurgitation velocity, the TAPSE, the dilation, the fractional area change, interdependence. At least these ones you should not miss. Also, look out for the causes of the right heart failure, whether there is any pulmonary embolism, whether there is any right heart mobile thrombus, whether 60-60 sign is present as in case of embolism. So all those things should not be missed out. Management, 5 pillars of the management of right heart failure are etiology and specific treatment, optimization of fluid administration with diuretic therapy and RRT, hemodynamic support with vasopressors and inotropes and inhaled vasodilators, ventilation, conventional or high flow NIV and mechanical ventilation, last but not the least, mechanical circulatory support. Coming to the first pillar, which is optimization of the fluid administration. Now, in case of RV, very much unlike the LV, we have preload reduction is required, okay, but vigorous fluid administration may result in decrease in the left ventricular output and cause hypotension through ventricular interdependence. And they might require, in case of an overload state, removal with loop diuretics like furosemide, or even sometimes RRT may be required. However, there is one particular condition like the right ventricular MI. Okay, the primary problem here is the decrease in the RV contractility and not the RV afterload, in contrast to the pulmonary embolism. So in this situation, the fluid increases the pressure ahead and consequently improves the cardiac output. So whether to give the fluid or not to give the fluid, one has to decide. Coming to the second point, which is the hemodynamic support. So hemodynamic support, maintenance of the MAP by the vasopressors. Norepinephrine, epinephrine, vasopressin, anyone can be used. The what is mostly the vasopressor of choice is the norepinephrine for all such cases, which targets alpha 1 to 3, basically alpha and beta. Increase in the systemic vascular resistance. It increases the peripheral vascular resistance and increases the heart rate contractility. Epinephrine, it increases the systemic vascular resistance, decreases the peripheral vascular resistance, and increases the heart, basically causes tachycardia. Vasopressin, it increases the systemic vascular resistance, decreases the pulmonary vascular resistance, okay, and decreases the heart rate and the contractility. Inotropes. So basically, inotropes, we have the dobutamine, milrinone, and here I have not mentioned the levosimendan. But in case of cases where there is hypotension, we usually do not use levosimendan or milrinone. We go with dobutamine. They cause decrease in the systemic vascular resistance, the peripheral vascular resistance, and increase in the heart rate and the contractility. Okay. Then obviously the phosphodiesterase inhibitor, we have the milrinone, and then we have the levosimendan, which is the calcium sensitizer. Another important entity is the inhaled vasodilators, which decreases the pulmonary vascular resistance. It may include inhaled nitric oxide, epoprostenol, milrinone, and nitroglycerin, and these are the drug doses. Etiology or the specific treatment. For example, pulmonary hypertension needs to be treated with all these endothelin receptor antagonists, prostacyclin analogs, calcium channel blockers, inhaled vasodilators, phosphodiesterase 5 inhibitors. Okay. Apart from that, mechanical obstruction alleviation, aortopulmonary shunting, lung transplantation might also be needed as a specific treatment. Correct the hypoxia, hypercarbia, acidosis. They worsen the HPV. Okay. So these things should be corrected. Rhythm stabilization in case of any arrhythmias is important, and correction of the underlying condition. Lung protective mechanical ventilation with a tidal volume of 4 to 6 ml per kg of predicted body weight, low peak pressure, and the P plat of less than equal to 30 millimeter of mercury is needed. The minimum PEEP is recommended. So what happens is when you give PEEP, the positive pressure reduces the venous return and the RV preload. At the same time, acidemia and ventilator-induced rise the transpulmonary pressure, increase the peripheral vascular resistance and the RV afterload. So PEEP is like a double-edged sword, okay? And as we say, optimum PEEP is needed, but for the right heart, keep it as minimum as possible. The intracorporeal microaxial pump, all the MCS devices are needed in case all the other therapies do not work. So, manage the primary cause, all right? Pathophysiology is important, whether it is a pressure overload, volume overload, or a myocardial disease, that is also important. Causes we have to remember, go with the volume adjustment, the inotropy, the perfusion, reduce the afterload, and the etiological treatment by treating the specific causes. In case of a refractory situation, go with the MCS devices. So this is the star slide for this topic. Coming to our next talk, which is on pulmonary hypertension. Okay, so pulmonary hypertension, first of all, the clinical classification of pulmonary hypertension, we have the class 1, 2, 3, 4, and 5. So, first are the causes of pulmonary arterial hypertension, the idiopathic, heritable, drug and toxin, okay, associated with certain diseases like connective tissue disease, HIV, portal hypertension, then schistosomiasis. All these are the causes of pulmonary arterial hypertension. Left heart disease, which is the most common out of the lot. We have the heart failure with preserved ejection fraction, reduced ejection fraction, valvular diseases, congenital diseases, then those with lung disease like restrictive obstructive lung diseases, okay, hypoventilation syndrome, hypoxia. So these are important. Those associated with pulmonary obstruction, and last but not the least, unclear mechanisms. So we also have the hemodynamic classification of definition of pulmonary hypertension, which is obtained by the right heart catheterization, and it includes the mean pulmonary arterial pressure of more than 20 millimeter of mercury, pulmonary artery wedge pressure of less than equal to 15 millimeter of mercury, and peripheral vascular resistance of more than 2 watt units. So important here is the precapillary, the postcapillary, and the combined. So these three are important. Anyways, pulmonary hypertension, you will have a pulmonary artery pressure of more than 20, but for precapillary and postcapillary, the differentiating point probably will be the pulmonary artery wedge pressure, which is less than 15 for precapillary, and for postcapillary more than 15, and the peripheral vascular resistance more than 2 watt unit for the precapillary, and for the postcapillary it is less than 2 watt unit. Coming to the pathophysiology. So the pathophysiology, there is a pulmonary vasculopathy. Okay. Pulmonary vasculopathy, basically we have the pulmonary, the right side of the heart, which is has the increase in the pressure. So there is an increase in the pressure causing the vascular changes in the pulmonary vessels. So basically pulmonary vasculopathy resulting in hypertrophy, internal proliferation, fibrosis, thrombosis, vasoconstriction. Okay, all those things worsen the proliferation and the fibrosis, which results in the pH, hypertrophy and dilation of the right ventricle, and further regurgitation of the tricuspid valve, increasing the pressure of the right side, resulting in a congestive cardiac failure. At the same time, there is constriction of the pulmonary artery, and the lung interstitial edema can be present. On the left side, what happens? So basically, when there is a pathology of the mitral valve, there is increase in the pressure of the LA. So the left side problem can also cause the right side problem. So usually it is pathology of the mitral valve, increase in the LA pressures causing the pulmonary vascular hypertrophy, and then we have the retrograde transmission uh, and elevated pressure of the LA, resulting in the back pressure and causing the right heart failure. Pathology of the aortic valve increases the left ventricular end diastolic pressure, and they can also result in right ventricular failure. If we go by the micro, or the micropathology, okay, there is medial hyperplasia, intimal proliferation, and plexiform lesions resulting in vascular obstructions basically. And the even micro pathway involves the endothelin pathway, the nitric oxide cyclic GMP pathway, and the prostacyclin pathway. Symptoms, we have the early symptoms and the late symptoms. So, dyspnea on exertion, fatigue, dyspnea on bending forward, that is the bandopnea, palpitation, hemoptysis, all syncope, weight gain due to fluid retention, all these are the early symptoms. Later on, patient can develop hoarseness, the Ortner's syndrome, exertional chest pain, all right, wheezing, coughing, all those things they can have. Then, coming to the signs, Signs of pulmonary hypertension: patient can come with mixed cyanosis, right ventricular third heart sound, systolic murmur of the tricuspid regurgitation, diastolic murmur of the pulmonary regurgitation. Okay, they can come with right ventricular backward failure, that is due to back pressure. They can have all the congestion on the right side, hepatomegaly, ascites, edema, distension, raised JVP. Signs pointing towards the underlying cause of the pulmonary hypertension, where we have the cyanotic heart diseases, bronchiectasis, Eisenmenger syndrome. So all of these might come with an underlying pathology sign. And the right ventricle forward failure, patient can come with dizziness, pallor, cool extremities, peripheral cyanosis, and prolonged capillary refill time. Now, the ECG findings, P pulmonale, patient can have right axis deviation, right ventricular hypertrophy, bundle branch block, right ventricular strain pattern, and prolonged QTC can also be found. Uh, Features of the pulmonary hypertension, left heart disease, and lung disease can also be found in the chest X-ray. Okay. Other functions which are recommended are pulmonary function test, lung scintigraphy, ABG, chest CT, cardiopulmonary exercise testing, right heart catheterization, and cardiac MRI. Echo findings. So echo findings, very much like uh, the previous findings, there is an enlarged right ventricle, okay, RV by LV ratio of more than 1, flattened septum, distended inferior vena cava, okay. Then the right ventricular fractional change area of less than 35%, TAPSE of less than 18, peak systolic velocity of the tricuspid annulus of less than 9.5, enlarged right atrial area of more than 18 centimeters square, the peak TRV of more than 2.8 meter per second, and presence of pericardial effusion can also be found. So, what is the goal of therapy? The goal of therapy is defined by the risk category. So, the risk category is defined by the WHO functional classification, the 6-minute walk, the distance test, the BNP, and the anti-pro BNP. The goal of the test is to achieve the goal of therapy is to achieve a low risk uh, state from the intermediate or the high risk state. Okay. So, the low risk, meaning WHO functional class of 1 or 2, 6-minute walking distance of more than 440 meters, and the BNP levels of less than 50 or anti-pro BNP of less than 300. The ultimate treatment goal is sometimes described as achieving a cure, signifying complete remission of the pulmonary hypertension without the necessity of ongoing treatment. So, we have the specific or the definitive treatment in terms of the pharmacotherapy when it comes to the pulmonary hypertension. And basically, these include calcium channel blockers, endothelin receptor antagonist, the phosphodiesterase 5 inhibitors with sildenafil and tadalafil. We have to remember some of them, including the doses: prostacyclin analogs with inhalational iloprost of 2.5 microgram 6 to 9 times per day, and the remaining are subcat or IV. Okay, treproprostanil is also given as an inhalational dose. Then we have the prostacyclin receptor agonists, or the analogs, which are given orally, that is selexipag, and then the recent sotatercept, which is the activin receptor ligand. So these are the pharmacotherapies which are available. And what is vasoreactivity and calcium channel blocker? So it is a physiological response of the pulmonary artery to a pulmonary vasodilator, a response that identifies the patients with pulmonary artery hypertension who may benefit from the treatment of this calcium channel blockers. Okay. And it is recommended in idiopathic, hereditary, and drug associated PAH. So the responders are who? Responders are basically those which fall in the mean pulmonary artery pressure of more than 10 millimeter of mercury to a value of less than 40 millimeter of mercury, and there is increased or unchanged cardiac output. The commonly drug doses are epoprostenol, adenosine, and nitric oxide. So these are the drugs which are used for vasoreactivity testing. But vasoreactivity testing can only be done at a tertiary center where there is high monitoring. Normally, these days, it is not done. Calcium channel blocker, even though it is a treatment where patients with a positive vasoreactive reactive state, they respond to high dose calcium channel blockers. However, calcium channel is not used as a uh, testing marker for vasoreactivity testing. So whenever a patient, so this is the most important algorithm that one has to know, and a lot of people are confused with this algorithm. So pulmonary hypertension, arterial hypertension, uh, whether the acute vasoreactivity testing is needed or not needed. Okay, so if it is needed, as we have seen in the idiopathic, hereditary, and drug classification, if they are responders, then go for high dose oral calcium channels. Okay, if it is a sustained response, then continue with the calcium channel blockers. If no, then determine the WHO class. And if the vasoreactive testing is not indicated in such patients, then directly define the WHO class, which is WHO class 1, 2, 3, 4, which is nothing but the functional class of 1, 2, 3, 4, which we have studied in the first slide. Okay. For class 1 patient, observation and treat the contributing factors. For class 2, that is the left heart failure patients, go for what is the preferred? The preferred treatment is an ambrisentan plus a tadalafil. Okay. Other combinations may be combined, single agent therapy may be given, but this is the preferred ambrisentan with tadalafil. This is the first line. For WHO class 3, okay, ambrisentan and tadalafil is the first line, but alternatives for a rapidly progressive disease can be epoprostenol, inhaled iloprost, or treprostinil, which is the prostacyclin analogs. Okay, and class 4, you directly go for a prostacyclin analog. If no improvement or deterioration is noted, then double or triple therapy is combined. If still no improvement is noted, then go for a lung transplant or an atrial septostomy. Apart from that, the baseline parameters of right heart failure, all of those will persist to treat hypoxemia, inhaled pulmonary vasodilators, treat hypotension, vasopressors are needed, dysrhythmia, treat arrhythmias, avoid hypoxia, hypercapnia, acidemia, inotropic support, uh, all those things. Whatever we have learned in the right heart failure will be needed here as well. And this is the star slide where you know the classification. Okay. And then we have the therapeutic strategies for each of them. Our next topic is a pulmonary embolism. Okay. So this you cannot not read. You have to know the stratification of pulmonary embolism. Acute pulmonary embolism can be divided into low risk, intermediate risk, or high risk. Sometimes people divide it as low risk, submassive, and massive. So submassive is nothing but these two parameters. Submassive is divided into intermediate low risk and intermediate high risk. And then you have the massive, which is the high risk. So the low risk patient is normotensive. The simplified PESI score is equal to 0. What are these scoring systems? We will read in the subsequent slides. Okay. So simplified PESI score is 0. Patient does not come with a dysfunction. The RV is normal in size and function, and there is normal cardiac biomarkers with no myocardial strain. The mortality is around 1.1% only. Intermediate risk. Now, intermediate risk is divided into two. Okay, we have the intermediate low risk and the high risk. But what differentiates the intermediate and the low risk and high risk is the last one. So basically, simplified PESI is more than equal to 1 and patient comes with a normotension. However, in the first one, presence of an RV dysfunction or myocardial strain, which is the elevated cardiac biomarkers, any one of them may be present. But in the intermediate high risk, both of them are present. That is elevated cardiac biomarkers with the presence of an RV dysfunction. In a high risk or a massive risk, apart from the RV dysfunction, patient has come in a state of shock. There is hypotension of less than 90 millimeter of mercury of systolic blood pressure with a drop or a drop of more than 40 millimeter of mercury from the baseline for at least 15 minutes. Requirement of vasopressor support, simplified PESI more than equal to 1, and the presence of an RV strain, dilation, dysfunction, myocardial strain with elevated cardiac markers. Everything is present in the high risk. Now, the 30-day mortality for the submassive is around 15.5%, and for a high risk or a massive is around 65%. Coming to what we read as the PESI score. Okay. So even if you don't remember the entire original PESI score, please try remembering at least the simplified PESI score. So simplified PESI consists of what? It consists of age comprising of 1 point, cancer comprising of 1 point. Then we have this chronic heart failure, chronic pulmonary disease comprising of 1 point, tachycardia of more than 110 comprising of 1 point, hypotension 1 point, and arterial oxygenation, the hemoglobin, oxyhemoglobin saturation of less than 90%, that is 1 point. So even if you don't remember this, please make sure to read this. And as we said, 0 point, okay, and more than equal to 1 point. In the previous slide, you have seen, apart from the low risk, the rest of them all have more than equal to 1 simplified PESI score. So 0 points has a 30-day mortality of 1%, and more than equal to 1 point, 30-day mortality is around 10.9%. Pathophysiology. Pathophysiology here very similar to what we have been studying before. The increase in the RV afterload, RV dilation, increase in the right ventricular tension, myocardial inflammation, demand increases, there is ischemia, hypoxic injury, decrease in the contractility, decrease in the RV output, decrease in the LV preload, decrease in the cardiac output, hypotension. So basically whatever we have studied for a right heart failure, you can just put it here. In the end, patient comes with a can have develop an obstructive shock and death. Now, decision to test in outpatient testing for pulmonary embolism. Again, this is very, very important. Okay. So, first of all, one has to have a high sense of suspicion for pulmonary embolism in the outpatient department. Okay. Which comes to our pulmonary embolism rule out criteria. So, pulmonary embolism rule out criteria, patient has to have a very high, this we will be again discussing in the subsequent slides. So if there is a high likelihood, that is more than 15%, then we choose to do the next set of basically scoring systems for the patient. If there is a less than 15% likelihood of pulmonary embolism or an implicit sense of pulmonary embolism, and the PERC is positive, we can still choose one of these chosen strategies, okay, to decide on whether the patient has a pulmonary embolism or not. However, if the pulmonary embolism rule out criteria is negative and the judgment of the clinician is also negative, estimated likelihood, then you rule out the pulmonary embolism. Okay, so we have to have a combination of symptoms and clinical findings with predisposing factors to have the clinical or the pre-testing probability. So the pre-test assessment can be done either by implicit clinical judgment or by using prediction rules. As I said, this is the implicit clinical judgment, but if we are still unsure, we go for the prediction rules. Okay, the prediction rules, basically what it comprises of, we have the Wells or the Geneva score. The Wells score of less than 4, revised Geneva score of less than equal to 10, and simplified Geneva score of less than equal to 4. Okay, along with a D-dimer option. If the D-dimer levels are less than 1000 or it is less than the age adjusted cutoff or the manufacturer recommended cutoff, if this is there, okay, then P is ruled out. However, if the Wells score is more than equal to 4, the Geneva score is more than equal to 10, and the simplified Geneva score is more than 4, this along with a D-dimer cutoff which is higher than the specified threshold, then we have to have a high suspicion of PE and we have to follow the next set of investigations. Okay. What are the risk factors? So a lot of people again are confused with the risk factors, whether it is a low risk or a high risk. So this has been by the AHA guidelines. The risk factor for pulmonary embolism, low threshold or the low risk, the major transient or reversible factors associated with more than 10-fold increase for the index of venous thrombosis as well. Okay, so examples are surgery with general anesthesia for more than 30 minutes, confined to bed in the hospital for more than equal to 3 days due to acute illness or acute exacerbation of any chronic illness, trauma with fractures. Okay, this is a low risk. Coming to intermediate risk are we can divide it into transient or reversible factors, the non-malignant persistent risk factors, or no identifiable risk factor. So the transient factors are minor surgery, less than 30 minutes. Okay. Then we have admission to hospital for less than 3 days with acute illness, estrogen therapy, pregnancy, confined to hospital days for more than equal to 3 days with an acute illness, leg injury. Leg injury is important. Okay. Any leg injury associated with reduced mobility for more than equal to 3 days. Please do not confuse it with trauma with fractures. And long haul flight. Patient has taken a flight from New York to India. Okay. Long haul flight. Then new non-malignant persistent risk factors like inflammatory bowel disease, active autoimmune disease. These are all intermediate risk factors, and the high risk factors are active cancer when patient has had a previous history of VTE, antiphospholipid syndrome. So these are the risk factors. Coming to either you can remember that or you can directly remember the scores. So the scoring system, there is no in and out. You just have to remember these scoring systems. So we have the well score. The well score, what are the pointers? The P most likely diagnosis 3. Signs and symptoms of DVT 3 points. Tachycardia more than 100 1.5 points. Previous 4-week immobilization for more than 3 days or surgery 1.5 points. Previous DVT or PE 1.5 points. Hemoptysis and cancer 1 point. So these are the criteria, and as we have seen in the previous slide, the well score of 4 is the cutoff for the well score. Okay. Likewise, you need to read off the Geneva score as well as the PERC score. This is all mugging up. No one can give you a shortcut for it. So just read it, and at least if you cannot remember all the scores, remember at least the well score, okay, and the simplified Geneva score. So diagnostics, we have CTPA, okay. Then the VQ scanning, VQ SPECT, pulmonary angiography, D-dimer testing, compression ultrasonography, and MRA. So MRA is not recommended for the diagnosis, but it is still one of the diagnostics that can be used in case other things don't help. Echo, we have discussed time and again, so I will not dwell into the detail of it. One thing you need to remember is the 60-60 sign, okay, and the McConnell sign, which is the sorry, the McConnell sign, this one, which is the free floating of the septum, and this one, the right ventricle, and the 60-60 sign, where you have the coexistence of the acceleration time of the pulmonary ejection of less than 60, and the mid systolic notch with mildly elevated peak systolic gradient of less than 60 millimeter of mercury. So at least these two you have to remember, with the remaining of them, which is very similar to the right heart failure. Chest X-ray, focal oligemia. Then you have the Pallas sign, the Fleshner sign, and the Chang sign with Hampton's hump. ECG findings of right ventricular stain S1Q3T3, not found in all the patients, found in only 10 to 15% of the patients. Then RBBB and P pulmonale might also be present. Patient can also present with atrial fibrillation and low voltage QRS, and the laboratory markers. Now coming to the approach to the treatment of acute pulmonary embolism. So in the above slides, we have established basically the approach to the decision making of a pulmonary embolism, whether pulmonary patient has a pulmonary embolism or not. Now what we are doing is what next needs to be done. So if the assess for the stability of the patient, okay, if the patient is hemodynamically stable, all right, anticoagulation or inferior vena filter can be considered. But before that, you need to assess for the right ventricular dysfunction. Right ventricular dysfunction, go for echocardiography, multi-detector CT. While you know that CTPA is what needs to be done, but there are times when you cannot do a CTPA, and at that time, patient has to undergo other things. For example, a bedside echocardiography you'll have to depend on. You will have to depend on a VQ scan. All right. Plus, uh, assessment for the RV injury with elevated cardiac biomarkers. So that is what we have to see. In case of hemodynamically unstable patient, as I said, CTPA might not help. A more helpful parameter probably would be an echocardiography. All right. Uh, so if there is no dysfunction or injury, basically patient has come in a low state, okay, continue the regular treatment. All right. You can consider anticoagulation. If the patient has come with a dysfunction, so the main confusion is between the intermediate low risk and intermediate high risk state. So when there is an intermediate low risk state, we go for an anticoagulation. When there is an intermediate high risk state, we go for an anticoagulation with a thrombolysis. And when there is a dysfunction and an injury together, then you go for all the other parameters. Okay. Apart from that, go for the regular support, volume optimization, vasopressors and inotropes, mechanical circulatory support, and the advanced life support. The drugs for anticoagulation are as follows. Okay, enoxaparin, dalteparin, doses you have to remember, and the deperfusion therapy with IV thrombolysis. One needs to know the trials for them. Alteplase 100 milligram over 2 hours is given. Retiplase 10 milligram bolus, which is repeat after 30 minutes, and tenecteplase dose depending on the weight is 30 to 50 milligram bolus. Now here one has to remember the trials. For alteplase, the trial was moped trial. Okay, heparin with alteplase versus heparin with placebo. It was found that heparin with alteplase decreases the hospital mortality and also the clinical deterioration in the patient. And tenecteplase, we have the types, the top coat and the patho trial. The types and the top coat showed favorable composite outcome. The patho trial showed non-significant reduction in the mortality. That is, the hemodynamic decompensation or the death within 7 days was 2.6% versus 5.6% for the placebo. However, there was more bleeding found in the interventional group compared to the placebo group. Other treatment modalities are catheter-directed therapies. We have the catheter-directed thrombolysis, the ultrasound-assisted thrombolysis, which is set, these two together are set to help attain the hemodynamic stability as seen in the Ultima and the Seattle trial, rheolytic thrombectomy, suction thrombectomy, and rotational thrombectomy and aspiration, which has the flare and the flame trial. Just remembering the names of the trials are enough. Okay, so this is the single line, uh, the single page if you have to read before the exams: diagnostics and risk assessment, anticoagulation, thrombolysis. Okay, systemic thrombolysis, catheter directed thrombolysis, or embolectomy, one has to know. All right, risk prognostication with low risk, intermediate risk, and high risk, which we have studied all the risk scores along with RV dysfunction, biomarkers, hemodynamics, and finally the treatment. Okay, do not forget to mention all the other treatment for the pulmonary embolism. IABP and mechanical circulatory devices. So within this framework, we have uh, an overview view of the mechanical circulatory devices with appropriate device selection, escalation strategies, management in intensive care, and de-escalating of the MCS. So if we see the definition of cardiogenic shock, if we have to see, it comprises of hypotension state with low cardiac output with signs of organ hypoperfusion. Okay, signs of organ hypoperfusion being cool extremities, altered mental status, oliguria, elevated serum lactate levels, hypotension, and obviously a cardiac index of less than 1.8 liter per minute per meter square without support and less than 2.2 liter per minute uh, with support. Okay, then it is divided into the three classification, which is the sky classification, beginning with at risk, beginning, classical, deterioration, and extremis. Then we have the hemodynamic profile, which is the LV congestion, biventricular congestion. Then we have the hypovolemic and the RV congestion, and the phenotypic classification involving the biventricular failure, involving the liver, or involving the kidneys. So these stages of classification, the sky, the hemodynamic, and the phenotypic classification, everyone has to know. So why are we reading about cardiogenic shock? Because MCS is one of the things that is used in the cardiogenic shock, okay, as uh, a bridge to recovery, bridge to transplant, bridge to device, and bridge to decision making. And the goals for these devices should be optimize the tissue congestion and improve the left and right ventricular failure, that is decongest the patient. Then ventricular unloading, which is decrease in the ventricular mechanical power, reduction in the oxygen demand, reducing the valve stress, minimizing complications like the effective dose of the inotropes and the vasopressors, and the end organ perfusion by reducing the organ injury, optimizing the tissue perfusion, and the oxygen delivery. So the causes of cardiogenic shock which might warrant the escalation to these are the complications for the acute myocardial infarction, acute cardiomyopathy, advanced right-sided or left-sided heart failure, allograft failure, post-transplant RV failure, post-cardiotomy shock, refractory arrhythmias, drug overdoses causing these massive pulmonary embolism and cardiac arrest. Principles of escalation include patients with ongoing severe cardiogenic shock with persistently low cardiac index, cardiac power output of which is low, less than 0.6 watt, hypotension, inadequate lactate clearance, evidence of RV failure, profound hypoxemia, and recurrent ventricular tachycardia or ventricular fibrillation. Now coming to IABP. So IABP, the principle is the balloon is inflated during the diastole to increase the coronary perfusion and then deflated during systole to decrease the afterload. It aims to improve the myocardial oxygenation, increase the cardiac output, organ perfusion with reduction in the ventricular the workload. Indications mainly cardiogenic shock, post bypass, post MI, mainly all the ones which we have studied uh, in the previous slide. However, what more than indications, what we need to know is the contraindication where it is not used: aortic regurgitation, aortic dissection, severe aortoiliac or peripheral vascular disease, aneurysm or other anatomical disease of aorta, prosthetic aortic tree grafts, local sepsis, lack of experience with management, severe coagulopathy, and not effective in the setting of cardiac index of less than 1.2, and tachyarrhythmias. IABP has two parts. Basically, there is a large bore catheter. So where one needs to know that a there is a large bore catheter. Okay, so catheter with like a sausage with a distal tip, and there is a balloon, and this is connected to a console. Okay, so there's a helium tube which is ends with a balloon and a distal tip, and there is a console. Okay, and the balloon is made of a polyurethane membrane. The catheter sizes can be varied with the balloon size chosen according to the height. It can be between 25 to 50 cc. They may be sheathed or sheathless. Why is helium used to inflate the balloon? Because it has a low density and it is less turbulent compared to that of other gases. So the balloon can inflate fast and deflate slowly. It is relatively benign and eliminated quickly if there is a leak or a balloon rupture. When inflated, the balloon occludes the aorta by 80 to 90%. Confirmation of the position. How do you check? So one is by the normal morphology and the timing of inflation and deflation with 1:2 augmentation ratio. The other is using a chest X-ray where the radio opaque tip lies in the second intercostal space right above the left main bronchus. Triggering and timing. So the balloon is timed to inflate and deflate with respect to the cardiac cycle. And the trigger options, one is the ECG. So ECG using the R wave to identify the onset of systole. If the sinus rhythm, if it is a sinus rhythm, then deflation can be for a set time period. In case of AF, the deflation occur depending on the when the R waves are sensed. And if the rhythm is paced, then pacing spikes can be used to detect the cardiac cycle event. Okay, so what happens during the inflation, during the diastole? There is augmentation of diastolic pressure, increase in the coronary perfusion, and increase in the myocardial oxygen supply. During the deflation, during systole, there is decrease in the afterload, decrease in the cardiac work, decrease in the myocardial oxygen consumption, and increase in the cardiac output. So very important, the waveform of the IABP. So we have first the unassisted aortic end diastolic pressure. Okay, the non-augmented systolic pressure. All right. Ideally, we have this kind of a waveform, right? So this is our arterial waveform. But when you have in the IABP, when you have the augmentation, then you have the augmented diastolic waveform. All right. Then the reduced aortic end diastolic pressure and the reduced systolic pressure. Okay. So the end aortic end diastolic pressure, it is lower than that of the unassisted aortic end diastolic pressure. Okay, the augmented diastolic pressure is always the peak and it is up than that of the non-augmented systolic pressure, and the reduced the systolic pressure, that will always be lower than the non-augmented systolic pressure. So these are the features of the IABP waveform that one has to remember. And the correct positioning, the balloon is just distal to the left subclavian artery 2 centimeter above the left main bronchus. So and the slope of the augmented diastolic wave is straight and parallel to the systolic upstroke. Coming to the troubleshooting. So, what are the problems with the IABP waveforms? So, we can have an early inflation where the IABP is inflated well before the actual diastolic notch. Okay, so dicrotic notch, the inflation occurs early. So, what will happen? There is premature closure of the aortic wall, reduction in the stroke volume, increase in the left ventricular end diastolic volume, and increase in the left ventricular wall tension. So the treatment for this is delay the onset of the IAB inflation. Okay. Then we have the late inflation. So here what is happening is the diacrotic notch is visible much later than that of the actual area of the diacrotic notch. So the augmentation is less optimum. As you can see, the augmentation of the diastolic, the augmented diastole is much less than that of what it should have happened. And there is decrease in the perfusion pressure and volume to the coronaries. So adjust the timing such that the IABP inflates at the diacrotic notch. Early deflation, what is happening is there is no afterload reduction, and the assisted systole, the peak is the same as that of the unassisted systole. Ideally it should be less, right? It should be lower down, but it comes very at the same level as that of the systole. So this is one of the parameters which is glitching for early deflation, and we have to prolong the IABP inflation time. And last but not the least, we have the late deflation, okay, which causes the increase in the workload of the left ventricle and increase in the myocardial ventricle, the myocardial oxygen demand. So shorten the IABP inflation time in such cases. IABP Shock 2 trial, there was no difference in the 30-day, 1 year, or 6 year mortality, and there was no benefit with respect to the hemodynamic parameters, lactate levels, catecholamine doses, or kidney function. So basically, for cardiogenic support, it is just an adjunct without any mortality benefit. What are the other parameters, the other tools that we have apart from the IABP? So it can be divided into left ventricular assist device and the right ventricular assist device. So left ventricular assist device can again be divided based on the pulsatility, the axial flow, and the centrifugal flow, based on whether it is a continuous pump or a pulsatile pump, whether it is intracorporeal or whether it is extracorporeal. So when you write your answers, you can divide based, or you can just put this slide. And we have IABP, Impella CP, okay, we have the tandem heart, and we have the VA ECMO. And similarly, we have the right ventricular assist devices, where we have the axial flow with Impella RP and the centrifugal flow with the VA ECMO and the tandem RVIT and Protect Oxy RVIT. Okay, so what happens? IABP we have studied in detail. Tandem heart is what? You don't have to know the deep details of this, but what you need to know it is independent of the rhythm. It is less artificial service area than that of the ECMO. It is suitable for patients with aortic stenosis and prosthetic aortic valve. But however, it is usable in the LV dysfunction. All right. And however, it compared to these two devices, Impel and IABP, it is much more invasive. Okay, because the atrial septum is basically catheter passes to the atrial septum in case of tandem heart. Then we have the Impella. It is independent of ECG and pulse. It is relatively easy insertion in the cath lab, and no extracorporeal blood is used here. And ECMO will be discussing in details regarding the VA ECMO in the next few topics. Coming to the various features of each of these devices. So first of all, one has to remember that IABP, it provides only up to uh, 1 liter, okay, 0.5 to 1 liter per minute. That is the maximum cardiac flow it can provide. Impella depends on the type of Impella used. You have the 2.5, you have the 5, you have the Impella CP. So it can go up to 5 liters per minute depending on the type of Impella used. And the mechanism of the Impella is LV to aorta. Okay. That's the flow that happens. Tandem heart, 2.5 to 5 liters per minute, and the flow happens via from the LA to the aorta. All right. And last is the VA ECMO, which can give up to 7 liter per minute. Maximum implant days, IABP can be kept for weeks, Impella for 7 days, tandem heart for 14 days, and a VA ECMO, of course, it can be continued for weeks. Then we have the sheath size, the femoral size. These are all you'll have to mug up, unfortunately. Cardiac synchrony or the stable rhythm, Impella cannot be used, tandem heart cannot be used, and VA ECMO, they might not provide this cardiac synchrony. Then afterload reduction is maximum in case of so afterload increase is more in case of tandem heart, and in case of VA ECMO it is the highest. The decrease happens in case of IABP and Impella. MAP is maintained and highest in case of Impella, tandem heart, and the VA ECMO. Cardiac flow is maximum in case of Impella, the tandem heart, and the VA ECMO, and the cardiac power also is highest in these cases. Okay. And the left ventricular end diastolic pressure is decreased in Impella and tandem heart. Unfortunately, VA ECMO does not offload the left ventricle. Okay. And left ventricle preload, however, is decreased by the VA ECMO, but not so much. It is more by the Impella and that of the tandem heart. Coronary perfusion is highest with Impella and with case of IABP. Myocardial oxygen demand is decreased most in case of an Impella. Okay. Complications of these devices, you can divide it as pre-procedure, during procedure, and after procedure, early versus late, or you can divide it in this form: mechanical, cardiovascular, hematological, neurological, and infectious disease. So these are the complications where there can be device migration, device malfunction, valvular injury, chamber perforation, vascular injury, limb ischemia, access site hemorrhage. In case of IABP, you can have a balloon rupture, hematological hemolysis, thrombocytopenia, thromboembolism, hemorrhage, cerebrovascular accident, peripheral nerve injury, infection like sepsis, and access site infection. Okay, so this is what. Uh, and then we have the weaning strategies. The weaning strategies, I think the only thing that you need is this. Basically, the IABP can be weaned from 1:1 to 1:2 to 1:3, and gradually or alternatively may decrease the volume serially by 10 to 25%. Okay. And we can the standard weaning is every 2 to 3 hours, and lowest level before the decannulation for the IABP is 1:3. Okay. This is the it slide that you have to remember. Cardiogenic shock, cardiac index is less, hypotension, vasopressor requirement, organ perfusion, increase in the left ventricular end diastolic pressure, screen for the MCS depending on hemodynamic assessment, underlying diagnosis, goals, exit strategy, contraindication, organ failures. Okay. And then we will have for RV failure, the devices are you have the Protect Duo with oxygenator. Okay. No respiratory failure, if it is there, you could go with Impella and Protect Duo. If there is no respiratory failure for a biventricular failure, can go with a Bipella, Protect Duo plus Impella. Respiratory failure, if it exists along with a cardiogenic shock, then we have to go for a VA ECMO or a Protect TO with oxygenator plus Impella. In case of mild impairment in LV failure, go for an IABP. If no respiratory failure, with a very low cardiac index, go for Impella or tandem heart. If a respiratory failure is there along with a cardiogenic shock, then one has to go for a VA ECMO. So this is the star slide in among all the slides that we have discussed. So I think uh, I will stop here because we have two more topics by Dr. Priya, and then we are having sessions tomorrow. So we'll start with uh, this tomorrow. Dr. Priya, are you there?
Yeah, I'm there. Yeah. I'll take
Yeah.
over. Yeah.
Yeah, yeah. I think you can take over and finish off today because cardiac is a huge topic and will continue tomorrow.
Okay.
Okay.
Sure.
So from my side, I think this is the end for today. We have discussed around 10 topics today. If there are any queries, please do write up and let us know. Okay, we'll try to cover as much as possible. If not tomorrow, we will share the slides and share the articles with you so that you can read up and brush up all the topics before the exams. Thank you.